simple that you think you could respond to directly, you could do that in the chat.
Yeah.
Okay.
Joshua?
So if anyone is looking for the Portuguese translation and how to access that, you can see the instructions that are here. And we'll just give another minute or two for participants to join, and then we have really packed and exciting agenda, so we'll get started very soon. Okay, great. So we have a lot of panelists a lot of participants here, and give a second for people to see the instructions for accessing the translation. So we're going to go ahead and get started. I'll leave these up while we do our introduction. So please, Bernadette, go ahead and we can get started. Thank you.
So here I am. Maybe Jackie, could we put off quickly the screen or not? It's very firmly in my view. I will explain it again.
Sorry, what was the?
Would you mind to put off the big slide? I heard you say I'll keep it on for a while, but I'll explain it again.
Oh, okay.
Yeah?
Okay.
All right. Then I have a better view of who we are and who all is there. So good morning, good afternoon, and good evening to everyone who's joining on this webinar that is dedicated to early lessons from integrating monitoring and counseling of child development into routine health services in Kenya and Mozambique. My name is Bernadette Dalmats. I work for the World Health Organization, the Department of Maternal, Newborn, Child and Adolescent Health and Aging, where I lead a unit on child health and development, and it's my privilege to be the moderator on this webinar. So I'd like to start by thanking the conveners of this webinar, colleagues in PATH, the African Population and Health Research Center, the Harvard T.H. Chan School of Public Health, and the ECD Action Network for putting together an exciting program that we will discuss in the next 90 minutes. Just to remind ourselves, as was shown on the screen before, this webinar will be conducted in 2 languages, English and Portuguese, and in your Zoom you can see on the bottom the different functions, so there is interpretation where you can choose the language that's of your preference. So what about this webinar? In the next 90 minutes we are going to learn and discuss about 2 important initiatives that took place in Kenya and Mozambique to integrate interventions that support nurturing care for early childhood development in existing health systems and services. The work has aligned very well with the Nurturing Care Framework that was launched in 2018 and was a response to an ECD Lancet series, the 3rd, that came out in 2017, that really articulated the importance of starting early at a minimum at pregnancy with supporting caregivers and prospective parents in caring practices, and to sustaining that support in the first years of a child's life. So in this webinar, we will discuss work that PATH has been leading at the forefront of this agenda in seeking that integration into existing health systems of aspects of nurturing care. And so that work then has also benefited from evaluation studies that have looked at the acceptability and the feasibility of doing so, the facilitators and the barriers that might exist in systems to prevent uptake, both in terms of service delivery as well as the acceptance by caregivers, and we have information around some of the outcomes of what these interventions have generated. This is new information for us. It's important information. So we are looking, hopefully, I think, at an exciting 90 minutes where you are going to be active participants. To do so, please use the chat to introduce yourself and share comments. And if you have a specific question, use the Q&A to put your question there. We will monitor that folder of the Q&A, and then as we get towards the latter part of our session, we will start addressing those questions. So now, to get us started, let me ask first for all presenters and panelists to briefly put on the camera so you will get an idea of who you are going to interact with, and I will introduce individuals as they take their speaking slot one by one later. Sheila, Matthew. Dr. Caroline. Ms. Arla. Okay, colleagues will come back again as we move forward. So let me start now by introducing to you the first speaker. That's Ms. Manisa Tekim, who joins us from the Conrad L. and Hilton Foundation, where she leads the Early Childhood Development East and Southern Africa Initiative. Manisa is well versed in the field of early childhood development. I expect many in the audience have crossed paths with her. She has worked as a regional advisor for UNICEF in the Eastern and Southern Africa Regional Office, and in that capacity contributed actively to the work that is being discussed in this webinar. At this moment, she has responsibility to oversee a grant-making portfolio that seeks to improve caregiver well-being and early childhood development outcomes. Manisa, may I ask you to make the opening remarks?
Thank you so much, Bernadette. And please let me start off by saying good morning, good afternoon, good evening to all the colleagues joining us from across the world. I've seen messages from all over Nepal. I know that there are colleagues joining today from California and everywhere else in between and after. So thank you so much for making the time to join us today. We know how busy you are. I mean, in essence, as Bernadette says, the point of the discussion today is really to hear about some early learnings that are emerging from work being done in Mozambique and Kenya to integrate early childhood support into the health system. I think it's really about what's possible to do with the systems as we find them. And I think it's also about using evidence and information to interrogate what we do and to make sure we are sure about the interventions that we are supporting and wanting to scale. But I want to just take us a little bit back, because you'll get into the details of that with the speakers that come after me. And it's really fascinating what they have found out, to ask ourselves about why this is even important in the first place. And of course, Bernadette alluded to the work that has been done around nurturing care, around the nurturing care framework. I'm sure many of you can remember and visualize the circle that basically distills decades of evidence from economics, neuroscience, and human development about exactly what's needed to make sure that children are universally on the right track to development. And we know that there are various sectors that are important and supportive: education, of course, agriculture, social welfare, and the like. But there's one sector that is really just of such paramount importance, which is the health sector, because it probably is the only one that universally can come into contact with human beings during the most formative stage of their development, those first 1,000 days and beyond. And to support those young children and their caregivers is really such an important job that the health sector is uniquely positioned to support in. But we also know the challenges for the health sector, not least at the moment with dealing with the pandemic and the fragility of certain systems. So the question really is, how, given the health sector is now, can we support early childhood through that? And it's really about thinking about the mechanisms that already exist, for example, through the primary healthcare system. So antenatal care and postnatal care and nutrition support and immunization and the like. How can we make sure that every kind of touch point between the system and young children and their caregivers really can support holistic early childhood development? And that's essentially what we're looking at and discussing today. And I think as you hear from the other speakers that will follow me, and as we interrogate this model that's being discussed today, I think we have to think to ourselves, what are the policy changes that would be needed to make this a standard practice for the health system? What's the financing that's needed? What's the kind of workforce strengthening that's needed across the board? Not just community health workers, but if we think about the vast array of the health workforce that comes into contact with families, pediatricians, nurses, midwives, and the like, I think all the time we'll be asking ourselves what additional support the workforce is needed. And in the end, it comes down to one thing, which is the interaction between young children and their families behind closed doors in the household. And the question is, how best can we gear up the health system to systematically support parents and caregivers to do the best that they can by their young children? So I'm really excited to hear what's been learned so far and for us to take this discussion further and think how we can systematically support children and their families through our work with the health system. Thanks.
Thank you. Thank you very much, Manisa, for these remarks and for framing very nicely where our discussion is going to be placed today, and to provide an entry point to the next speaker, which is Svetlana Drevdal. Svetlana is the Senior Regional ECD Specialist for PATH, and she has actually dedicated the last 8 years to do exactly what Manisa was referring to, and that is to activate these existing touch points that are there in the health systems to do a little bit more and better to support early childhood development. She's stationed in Mozambique, but she supports a range of countries, including Kenya and Ethiopia, and her interests are both sort of geared about the provision of quality services as well as the capacity of learning from caregivers on how they are able to uptake the practices and the behaviors that are being promoted. So Svetlana, I'd like to invite you to make your presentation.
Thank you very much, Bernadette. I'll ask Jacqueline to help me with the presentation, please. I think currently it still shows the translation slide, unless you guys see a different slide than I do.
No, we still see the translation slide. Jacqueline, can you hear us? Would you be able to put up the master set?
Mm-hmm. Perfect.
Jacqueline, would you be able to change it to slideshow? Perfect. Yeah, I think we are good, Svetlana. Yeah.
Thank you very much. So as Bernadette mentioned, this is really just an introduction to understand what the studies have been looking at, what actually PASC has been supporting the two ministries, Ministry of Health in Kenya and Ministry of Health in Mozambique, to do over the last few years. Let's move to the next slide. So PASC has been working in the region in Southern and Eastern Africa and a little bit in the West Africa as well for the last 8 years. You can see the countries that we've been working in. So far, currently we are most active in Mozambique, Kenya, and Ethiopia. And overall, the approach is consistently similar across these countries, which is really working with primary health care at the facility and community level and trying to reinforce the touch points with ECD components. Let's move to the next slide. So since we're working with the health system, of course, our starting point was to see what's already in the health system. And what we found is that there were some guidelines or some initial documentation on developmental monitoring. So that was our starting point. And of course, we want to do much more than monitor for child development. So we built on that, reinforced developmental monitoring, supported the government when necessary to add indicators on child development, and then added what was missing. And what was missing in most systems was counseling on child development. Luckily, there is a tool that many of you know, a package, Care of Child Development. So that was our starting point to really bring in counseling, making it more user-friendly, provider-friendly, making it more visual. So you will see an example here of a poster that's used in Ethiopia, where we basically transformed CCD, Care of Child Development visual card, and outlined the counseling steps, which provider is using them in the key health consultations. We can move on. So as Bernadette said, and Maniza as well, we are really trying to support the government systems throughout the touch points. However, touch points differ, as many of you know yourselves. Some of them require much more intensive interventions because the children are more at risk, already have compromised development because of disabilities or HIV or malnutrition, and others are more preventive in nature. So what we've learned is that we cannot apply the same approach at all the touch points. At the bottom of the pyramid, which are more universal services, such as antenatal care, CHV home visits, well baby clinic, you really want to have key messages and maybe key educational activities on child development, but you usually cannot do more than that because the services are quick and don't allow for intensive counseling. However, as you engage with children who are more at risk, then you have more regular contacts, more frequent contacts, and usually more time either at home or at the health facility. So then we also try to kind of differentiate the type of tools and type of counseling that's happening as you move through the levels. We can move to the next one. What we've also learned is that it's really not enough to only work at the provision or implementation level. You really have to adopt a whole health system approach, which means working very closely with the national technical working groups, making sure that any type of learning that's happening on the ground is reflected in the pre-service curricula, in-service training modules, national plans and strategies, indicators are there, SOPs are there for the touch points, any developmental components appear in the quality improvement tools, and relevant job aids are available. So it's a process that kind of moving between two levels, national advocacy and subnational implementation. Let's move to the next slide. So of course, we've seen that there are some gains and challenges of this approach. Definitely, there is much greater adoption and ownership of the Nurturing Care for ECD agenda. When you work closely with government, the government really takes on and owns the agenda and accepts the interventions as part of its health system work. However, at the same time, changes sometimes are slow. It takes time to develop new policies, to adapt or revise pre-service curricula, SOPs. And unfortunately, implementation sometimes has certain challenges because maybe the quality of support supervision is not as strong. So often you need to bring additional supports outside of the government structures. And definitely we are seeing that there should be a bit more involvement of the donors, because often the donors are supporting similar interventions in nurturing care, nutrition, or MCH, but not necessarily thinking about child development as one of the areas that should be strengthened at the same time. And the last slide. Just to show that this approach is really not how should I say, not stagnant or not static. As we are implementing, we are learning. So very often we had to make adjustments in our approaches. If we notice that there is a particular intervention is weak, we are trying to make adjustments to them. For example, when we notice that the government-led supervision is not frequent or is really not focusing on quality of care, then we started looking at what could we do and who could we engage. For example, could we work with health facility directors as mentors because they're so much closer to the providers and could really make an impact. Or if we notice that there is a lack of written data analysis, really trying to help government to develop dashboards that would really visualize the data, make it available, and make it even more kind of salient for them and for their discussions. And so all these tweaks you will see reflected in the studies presented. And so the studies already kind of move on to the next level. We are really ready to engage in certain evaluation to share what we have learned through this tweaking and adaptation of the models. So thank you very much.
Thank you. Thank you, Svetlana, for giving us this overview of the approaches that you have taken to integrate components of that nurturing care framework, particularly responsive caregiving, early learning, aspects of safety and security, I think parts of maternal mental health, into sort of existing services where health and nutrition are already being promoted, all with the aim of kind of to make services strong so they pay attention to all 5 components of nurturing care, which we know are essential for children to develop their optimal potential. So with that, we are now going to look into the evaluation. I would like to say before we go there, welcome to newer participants. Look at your interpretation button in case you want to switch language. There is English and Portuguese. And as you have questions, please put them in the Q&A. Similar as Svetlana, there may be questions for your presentation. Please, colleagues, put them there. So we are now going to the first longer presentation on the evaluation of the efforts in health facility based services combined with home-based support by early childhood development in Monapo district in Nampula. And so I'm going to introduce Joshua Young, who is a development scientist, a research associate in the Department of Global Health and Population at the Harvard T.H. Chan School of Public Health. Joshua has a rich experience of evaluating parenting intervention, and he has a keen interest in sort of looking at the parent and family environment, including the role of men. He led the evaluation in Monapo district in Nampula, Mozambique, on the nurturing care pilot, and is going to share the results. Welcome, Joshua.
Hi, thank you, Bernadette. Good morning, good afternoon, good evening, everyone. As Bernadette said, I'll begin the first of the 2 presentations, which is the evaluation, which is a qualitative evaluation that we conducted in Monapo district, Mozambique. Before I begin, I would like to acknowledge the entire study team, which included other researchers at Harvard, Meraxis, who led the fieldwork in Mozambique, and PATH, who designed and oversaw the implementation of the pilot in Monapo. And the study could not have been possible without numerous study participants, partners in country who gave their time and contributed to developing this work, as well as the funders of the program implementation and evaluation. As Lana mentioned, the Nurturing Care for ECD pilot integrated multiple nurturing care interventions into various touch points of existing health services. So both at the primary health facility level, which is like a photo above, and through community health platforms. The pilot was conducted in 3 primary health facilities and their community catchment areas, and it began at the end of 2018, early 2019, and was rolled out for approximately a year and a half before we conducted the evaluation towards the end of 2020. There were 4 primary objectives of the pilot. The first, to strengthen capacities of government health systems and community-based platforms like community health workers, who are known as APEs, to integrate and deliver nurturing care interventions. The second was to increase children and caregivers' access to nurturing care interventions, for example, developmental monitoring and counseling on early learning and nutrition, as Lana mentioned. The third objective was to improve nurturing care knowledge and practices among caregivers towards the ultimate goal of contributing to better child development outcomes. This slide shows the theory of change for this pilot program, with the partners and delivery agents involved in the implementation on the far left in this black bucket. In the middle, the specific program components that were delivered at the health facility level and at the community level. And on the far right, the outputs and outcomes, both at the health system level and for caregivers and children. So in terms of the partners involved, the Ministry of Health oversaw the integration and delivery of services, and other NGO partners were engaged, particularly to deliver the community-based programs through various activist groups on the ground. PATH provided technical support and oversight, and UNICEF was involved in the coordination and some of these technical working groups. The delivery agents were existing personnel within the health system, so more specifically, health facility providers and community providers who all received supportive supervision from managers existing within their system. So for example, the health facility director or the APE, which are the community health workers, their supervisors who are already in that workforce, as well as higher level support from PATH district officers. And as I mentioned, the interventions were integrated into existing health services at the health facility as well as the community levels. And so these included monitoring of child developmental delays and malnutrition, counseling caregivers on nurturing care, the use of media, so video, radios, print media at the health facilities and radios in the community, as well as the integration of an indicator for child developmental delay in the HMIS system at the health facilities, as well as health facility referrals for children who were identified as having developmental delays in the community. And these interventions in turn were hypothesized to produce outputs, outcomes, and the ultimate, towards the ultimate child level outcome. And so we have outcomes both at the health system level. So for example, increasing provider acceptability of the interventions and ultimate sustainability of service delivery. And for caregivers and children, for example, increased caregiver nurturing care knowledge and practices, and ultimately better ECD outcomes. The overarching research goal for the study was to qualitatively evaluate the implementation of this multi-component, multi-level pilot, and specifically assess the delivery, acceptability, barriers and facilitators to implementation, and perceived changes resulting from the pilot. And we had 4 specific research questions. How, if at all, have stakeholders, providers, and caregivers engaged with the pilot? What is the acceptability of the pilot among stakeholders, providers, and caregivers? What changes, if any, do stakeholders, providers, and caregivers perceive as a result of the pilot, so at the health system provider and caregiver levels? And what are the barriers and facilitators to implementation or engagement in the pilot? We used a qualitative design to evaluate the implementation of the pilot. The pilot was implemented in 3 primary health facilities and their community catchment areas, and these 3 health facilities were prioritized through a consultative process with Ministry of Health officials. These data were collected by our field partner Meraxis in October and November 2020. And we incorporated various data collection methods, including in-depth interviews, health facility exit interviews, and direct observations at the health facilities. Data analysis was conducted by a team of 3 researchers who developed a codebook. Each conducted line-by-line coding of all transcripts and applied thematic content analysis. In total, the sample comprised of 73 respondents, which was stratified or distributed equally across the 3 health facility catchment areas. Half of the sample represented caregivers, so 36 caregivers of children under 2.5 years, the vast majority of whom are mothers. We interviewed 15 health facility providers who also represented various types of providers, 2 community-based providers, 12 community-based providers, and 10 stakeholder representatives, which included Ministry of Health officials, supervisors of community activists, and PATH field officers. In addition to the 73 in-depth interviews, we conducted 9 hours worth of observations at the 3 health facilities to observe the environment, service delivery, and interactions between providers and caregivers. The subsequent slides will highlight the key findings around these 4 research questions, and will be organized in terms of fidelity, which is adherence to delivery and program exposure, so what actually did the caregivers receive, respondents' acceptability of the pilot, perceived changes, and barriers and facilitators to program implementation. And the full details of the study results can be found in our manuscript published in the Annals of the New York Academy of Sciences, which I believe will circulate after to everyone on the call, which we also have a short Portuguese summary translation version of. So first we asked respondents about their roles in the program to understand fidelity of delivery. And Ministry of Health representatives and other stakeholders described various program activities relating to health system strengthening. So more specifically, respondents described building partnerships at the district and province level that centered around ECD. Respondents shared how new trainings and supportive supervision were provided to the providers to promote nurturing care. For example, this is a quote from Ministry of Health District Representative for MCH commenting about the ECD training that they conducted and the new knowledge that they learned. Respondents also mentioned other inputs that were introduced to improve quality of care, such as embedding an indicator into the HMIS system to monitor the number of children identified as having developmental delays and improving referrals for at-risk children, and developing a triage of care. So when children came, they would know which type of care or service was most appropriate for that young child to also help reduce waiting times. Providers also discussed delivering multiple nurturing care messages to caregivers. They most commonly focused on maternal and child health, nutrition, like exclusive breastfeeding and complementary feeding, and COVID-19 awareness and prevention. Monitoring of child developmental status and counseling caregivers on the importance of early learning and even father involvement were also mentioned. But the ECD specific topics were mostly mentioned by health facility providers and much less so by community providers like APEs or the community health workers. In terms of caregivers' exposure to services, health facility-based program components, and specifically the counseling from health facility providers, was a primary reported source of nurturing care information. So caregivers recalled various messages from health facility providers spanning nutrition, maternal and child health, COVID, as well as ECD milestones and early learning practices. Media in the waiting rooms of the health facility was a second most commonly reported source of nurturing care information. Most of this information from media that caregivers recalled was around COVID and nutrition. But parenting and ECD, on the other hand, was less commonly recalled and mostly through the posters and less so from TV or radio. Based on our observations, we noticed that the radio posters and TV were largely disseminated on their own, as in it wasn't accompanied by discussion or guided explanation of these messages in the waiting room. And TV in particular was the least commonly reported source, where we found actually that only 2 out of the 3 health facilities had the capacity to use a TV because they didn't have power. And we noticed that the placement of the TV was kind of limited given those electrical and infrastructure related constraints. This is a very long quote that I won't read, but it's just from one mother who recalled a number of different nurturing care messages from the posters, which spanned COVID, nutrition, and developmental milestones. Exposure to nurturing care services from community-based sources was much less common than health facility-based sources. Approximately half of caregivers reported exposure to media, specifically radios, at the household or community level, but most caregivers only mentioned COVID-19 messages from the radio. Just a handful recalled child development or nutrition messages via radio in the community. And finally, counseling from community health workers, or the APEs, was the least prominent source of nurturing care information in our study context. Only 4 out of the 36 sampled caregivers had any interactions with APEs, and of those who did, they said the APE services mostly focused on nutrition, family planning, and COVID, and none of them mentioned APE as a source of child development or parenting messages. Next, we asked stakeholders, providers, and caregivers to share their opinion about the acceptability of the pilot, and there was consensus that the services were highly acceptable. Stakeholders shared a new awareness and interest in ECD and how service delivery was improved, and the value of new multi-sectoral partnerships at the district and province level for child development. And this quote is from the district representative of maternal child health, And he highlights how he was very interested in messages about the importance of toys and how this was just his interest and satisfaction in this. Providers share their satisfaction with the training, supervision, and resources received, like job aids, and their perspectives also about the relevance and usefulness of nurturing care messages. And caregivers also express their interest in nurturing care messages, specifically highlighting their satisfaction with the interpersonal counseling skills of providers, specifically by health facility providers. And caregivers also talked about providers' patience, providers' ability to explain concepts clearly, and being friendly with them and their children. We asked stakeholders, providers, and caregivers to comment on any changes, whether that be positive or negative due to the pilot. And we organized these in this slide in terms of the changes at the health system level, the provider, and the caregiver level. District stakeholders and providers noted several positive changes at the health system level, like stronger partnerships with district stakeholders, more efficient health system operations and service delivery, increased capacity for system level monitoring of children at risk of developmental delays, and increased number of health facility referrals. Providers also highlighted many benefits, specifically new knowledge about ECD and its links with child nutrition. For example, this quote from one well-child consultation provider talks about her increased knowledge to monitor developmental milestones. I'll just quickly read it. Before the pilot, I was only dealing with the nutritional part, but I did not have that awareness of why is this child not sitting on their own and he is more than 6 months. I was worried, it was worrying, but we did not know how to act. I could only send the caregiver away because I had no information on how to deal with such a situation. Now everything is integrated. It is very beautiful. Now I take a toy and give it to the child and assess if the child can sit on their own or if he can reach it, if he can reach the toy without difficulties and hesitation. I also carry the child on my lap and examine the head, whether the child can balance its own head without falling. Many providers also shared how their confidence increased through the supervision and technical support received. However, at the same time, a few providers did share one negative impact. A few providers, health facility providers specifically, felt like they had more responsibilities and were overwhelmed by needing to counsel caregivers on parenting messages or child development messages when they were already overburdened with many patients and had very few staff. Finally, caregivers highlighted how they gained new knowledge on nurturing care and engaged in new and improved nurturing care behaviors, like preparing enriched forages, providing homemade toys for their children. And it's worth noting that caregivers mentioned care practices for child health and nutrition more frequently than early learning, which is consistent with the fact that caregivers recalled exposure to nutrition and health messages much more frequently, consistently than child development messages. And several mothers also mentioned how their male partners also became more engaged in playing communication with their children. The final research question pertained to the barriers and facilitators to implementation and uptake of the pilot. And there were several barriers identified at the health system level. So scarcity of providers was highlighted by stakeholders and providers as a major challenge, especially given the high patient volume that caused more workload for an individual provider. And this was especially true for community health workers, as there was only one community health worker per health facility area, or one or two. Also, high staff turnover was noted as affecting efforts like training and sustainability of service delivery. And this quote from the district representative for maternal child health highlights a health workforce challenge. A challenge for some colleagues is they might not know the information, but maybe because of time, they might know the information, but maybe because of time limitation, they opt not to follow. Maybe when they look outside and see the long queue. We also have a lack of human resources in the area. There's only one nurse for prenatal, maternity, family planning, all of this under the hands of a single nurse. Those with goodwill undertake the work. However, the work could still be deficient. There were also challenges that pertain to the infrastructure of the health facilities, such as limited waiting area space, lack of electricity, which I already mentioned. and others noted how there were gaps in the referral procedures, particularly around follow-up care for children after they left the health facility. A few barriers were noted at the provider level. Specifically, a handful of providers described feeling stressed by having to deliver additional ECD services, especially because they knew there were so many patients waiting and wanted to get through everyone as soon as possible. A few were described as having low motivation and being apathetic or resistant even to delivering the new services like the counseling on child development, which related in part to the stress and the environment of constrained health systems. Finally, at the caregiver level, poverty made it difficult for some caregivers to implement the recommended behaviors, like some caregivers sharing how they didn't have money to provide nutritious foods. Others talked about how a visit to the health facility could take up an entire day's time, with mothers walking up to an hour to get to the clinic. And we saw that everyone arrived super early in the morning, around 7 a.m., even waiting a couple hours before the clinic opened. And so that impacted their daily routines and responsibilities. Finally, for the facilitators, strong government leadership at both the district, provincial levels, what district and provincial levels was mentioned as a key factor for successfully mobilizing stakeholders and implementing this pilot. For example, one of the Path Field program officers explained the factors that enable our work to succeed in the district are involvement of the local leadership. I'm referring to huge involvement of the District Directorate for Health with management of the services at the health facility levels, such as the head doctor. The involvement of the health leaders, especially the local government, can sensitize the whole community, every political and decision makers. Providers emphasized how high quality training and supervision help them provide better support to caregivers and children, and particularly noted the technical supports like the refresher trainings, the on-the-job coaching, and the constructive feedback that they received. And finally, caregivers shared how they particularly found the interactive messages from the facility and community providers as helpful. And other caregivers talked about social support. Despite the study's strengths, which included a diverse group of respondents and triangulation of information across various perspectives, there are a number of limitations. First, our sample of caregivers focused on those who had visited the health facility for a child visit in the past month. So while everyone had some experience with the health facility service, the sampling did not also purposefully include caregivers who had, for example, been in contact with APEs. And so if we, in the future, interviewing APE beneficiaries can provide more detail about the fidelity and quality of the community-based services.
Joshua, a little alert.
Thank you. I'm wrapping up. In terms of timing, we were affected by the pandemic. Because this program was integrated into existing systems, respondents might not be entirely clear whether the findings are attributable to the pilot. And then finally, because it's a qualitative study, we can't comment on causal effects. So based on our results, we have 4 areas for improving future programming. The first is around the use of media, where one recommendation is to just have more standardization in the implementation, and also linking the media with counseling. The second recommendation is around addressing or strengthening the health system. And given some of these challenges of human workforce shortages, maybe having more trainings, and also engaging other delivery agents will be helpful for task sharing. The third is around improving and enhancing the focus of the way to support child development by incorporating more behavior change techniques and focusing on responsive caregiving. And finally, to improve continuity of care, building a protocol that supports follow-up after children go back into the community once they leave the health facility. So that concludes the presentation of the Mozambique study. I'm sorry I went over time, and I'll pass it over to Patricia, who will go into the Kenya study. Thank you.
Thank you very much, Joshua. And just a consolation, you did not go over time, you were just within it. So thank you for that very rich overview, looking at different aspects of the system, both the provision as well as the supply of services, the demand and the uptake of services by caregivers, and showing us these results that I'm sure will have generated lots of thoughts and comments that we will find in the Q&A and in the chat. But indeed, let's, without further ado, look at the other presentation from similar study findings in Siaya County in Kenya. And so I'd like to welcome Ms. Patricia Tsao-Wekelo, who is an associate research scientist at the African Population and Health Research Center. She has been involved in research with children for many years and is highly motivated to advance the understanding of health and social determinants of early childhood development. Patricia, I'd like to hand the word for you to lead us through the presentation.
Thank you, Bernadette. Good morning, good afternoon, good evening, everyone. Jacqueline, I would like to ask that you put it in slideshow.
I'm trying, for some reason it's not working. Let me keep trying.
Okay, so the presentation I'm going to make is based on the study that we carried out in Kenya, which Lana has touched on a little, and we wanted to evaluate the feasibility and effectiveness of an ECD intervention in Siaya County. The study was implemented by the Ministry of Health in collaboration with PATH, and the funding that we received to carry out this study was from the Elmer Foundation and the Conrad Hilton Foundation. A brief background, maybe you can go to the third slide, Jackie. Okay, so just a brief background. We see that the statistics for Kenya are very poor in terms of children's optimal development. More than a quarter are stunted, and 41, close to half, live below the poverty line. And then in terms of those who are engaged in early learning activities, it's up to 75%. These are statistics, these are ranges for across the entire country. So we can see that engagement with young children is not yet at the level that we would like it to be. Now, for Siaya, the statistics show that nearly 25% of the young children under 5 years are stunted, which is one of the motivations for carrying out this study in Siaya County, just to try and make some changes in the outcomes for the young population in this area. The intervention that we evaluated was, I already mentioned, carried out in partnership with in a partnership between PATH and the Siaya County Ministry of Health. And Lana already spoke about the intervention, so I won't go into detail on that. The next slide, please. So we see that the intervention was carried out at the health facility, and it comprised training and mentoring of facility-based health service providers and community health volunteers. And then there was also child development monitoring and counseling at the facility level. CHVs were tasked with the responsibility of facilitating playbox sessions in the facility waiting areas. And then they also carried out home visits in which they integrated ECD counseling. The pathways of influence are similar to what Josh presented. We hypothesized that because of the training that the health service providers received, we hypothesized that this would result in increased knowledge among themselves, and then increased knowledge among the caregivers. And this in turn would result in improved interactions between caregivers and their young children. And then ultimately the impact we wanted to see was that children's developmental outcomes improve. Next slide, please. The APHRC team evaluated the model for three main reasons. We wanted to assess the feasibility and acceptability of integrating ECD into the health system. We wanted to determine the effectiveness of effectiveness in improving caregivers, ECD, knowledge, attitudes, and practices, and children's developmental outcomes. And then we wanted to estimate the cost and cost effectiveness from the provider's perspective. So I'll go to the feasibility and acceptability results. Jacqueline, next slide, please. Actually, 2 slides away. The feasibility and acceptability results are similar to what Josh has just presented. And one of the 2 questions that we had for the feasibility, we wanted to find out how well the ECD intervention worked within the health system. And then we wanted to find out also if the integration of ECD into the health system was perceived to be acceptable and useful. The feasibility study was mainly carried out through qualitative interviews, and we had different respondents being interviewed through different qualitative interviews. We had FGDs, we had in-depth interviews, we had key informant interviews, and we had different numbers being interviewed using the different tools. So that's the slide showing the numbers for each participant group. Now, for the feasibility, one of the things that we looked at under feasibility was performance of the intervention. And here we saw that in general, participants perceived that the intervention performed well in terms of improving childcare knowledge, awareness of the importance of play, and their ability to identify developmental delays. We can see some quotes in the next slide. So we can see from an IDI with the primary caregiver, one of the primary caregivers says, from that teaching, we're able to identify what children like and make them toys with regards to what their interests are. Since I got the teachings, I now allow my baby to play with other children and I make toys so that he can play with them. So that's just an example of a quote from one of the participants. Now, the next aspect of feasibility that we looked at was in terms of the information provided. And here the different participants mentioned that they received information on different aspects. For example, caregivers reported that they learned about the importance of early ANC visits. Next slide, please. They also learned the importance of talking to the unborn child. And Josh also showed in one of the quotes that the participants mentioned that it was important to engage with the child while they were still in the womb. And then caregivers also mentioned that they learned the importance of play for child growth and development. We had that male caregivers, they reported that they had become enlightened on the importance of sharing responsibilities within the home, both related to household chores and child caregiving responsibilities. And then the training improved CHV efficiency in the playbook sessions and in the ECD home visits that they carried out. Healthcare providers on their part mentioned that they understood the brain behavior link better because of the training that they received. Another aspect that we looked at in terms under feasibility was on implementation, and generally the intervention was perceived to fit well within the existing health system infrastructure. County staff provided support supervision to sub-county staff on a quarterly basis, and this seemed to work very well throughout the implementation period. The inception of the intervention, before the implementation activities began, there was a lot of stakeholder engagement, and because of this, it resulted in community buy-in and success of the implementation. Another aspect of the feasibility that we looked at was the barriers and facilitators. And we saw that some of the facilitators, and Josh also mentioned some of these. Next slide, please. Some of the facilitators were a strong community health system. And there was also a supportive health system that enhanced the implementation of the intervention. The availability of reference materials was also a strong facilitator for implementation. Some of the barriers, and this also Josh already mentioned, high staff workloads, and then staff transfers. This staff transfers, one of the issues that arose from this was that after staff in a specific facility had been trained on the nurturing care framework, the transfer meant that they were transferred with the knowledge that they had received, which meant that the new staff that had been placed in that health facility needed to be trained on the nurturing care, which caused a bit of implementation issues. And then another barrier that was noted was the lack of resources. And then there were also pockets of community resistance. This one is related to the male caregiver involvement. Some of the male caregivers wanted to accompany their wives to the health facilities, but then they felt, or they reported that other males within the community laughed at them because they said going to the health facility is a woman's responsibility. So they were wondering why the men were going to the health facility with their wives. But generally there was acceptance of the intervention within the community. Another aspect of acceptability, another aspect of feasibility that we looked at is in relation to the acceptability of the intervention. And here under acceptability, we looked at satisfaction and support. Caregivers reported that the long waiting times that they used to experience earlier before the intervention became more bearable because children now were engaged in the play boxes in the health facilities. CHVs reported more motivation, and then the caregivers also reported the benefits in different aspects. Male caregivers also became more interested and contributed to the sessions on the nurturing care. Now, in terms of the support that was provided by the different participant types, you can see the activities and the ticks signify the different participants that supported that aspect. So for example, the making of play items, these are caregivers and CHVs, and then facilitation of the health talks and the playbox sessions. This one was supported by the caregivers, the CHVs, and the healthcare workers. And then the health management team at both the county and the sub-county level supported on the job training for health staff, supervision and mentorship, and also capacity building. We also, one of the things that came out of the qualitative interviews was perceived sustainability of the intervention. And one of the aspects that was an illustration of the sustainability of the implementation was that the intervention leverages the existing health system. This was seen to be an aspect that would promote sustainability. And then the use of locally available materials was reported as a strong factor on sustainability. Engagement of local community members was also another aspect on sustainability. And then sustained supply of play materials, provision of training and supervision, and then the way the county government spearheaded the implementation of the intervention was a strong factor in sustainability. Another theme that we looked at under the feasibility was adaptation and scaling. Please move to the next slide. Under adaptation and scaling, some of the suggestions that were made by the participants was that the language used on the IEC materials could be changed from the onset, rather than changing it after the implementation had already begun. And then they also suggested that the curriculum, the level of training and number of days to be adapted to the needs of participants, because some of the participants, the curriculum was a bit too technical for them, and maybe there needs to be consideration for scaling the level of the curriculum so that it's appropriate for the different levels. And then another aspect on adaptation, expansion of the intervention was perceived to be possible through other stakeholders such as the church. Now I'll move on to the effectiveness study. And here I'm reporting on the quantitative aspect of the study. This was carried out as a 3-armed cluster randomized control trial. Arm 1 received the health facility-based ECD counseling. Arm 2 received the health facility plus home-based ECD counseling. And then the Arm 3 was the control. They received the standard MOH, Ministry of Health standard care. We recruited 792 caregivers at baseline, and we followed them up to when the children were aged between 24 and 27 months. So our baseline is when the children were aged 1 to 2 months. Our midline, at midline, the children were aged 9 to 10 months, and at endline, the children were aged 24 to 27 months. We used Uncover. We analyzed the data using Uncover, and we analyzed the panel data. And the panel data is those who were seen at 2 time points. So for example, for the midline, which is the post-birth 2, we compared the baseline data to the caregivers who were seen when their children were aged between 9 and 10 months. And then endline, we compared those who appeared at baseline and those who presented themselves when their children were aged 24 to 27 months. We carried out a separate analysis to establish those who received the intervention. Looking at the results.
Patricia, may I alert you have 5 minutes to round up? Would you?
Okay,
would that be possible? Yeah.
That's okay, that's okay. Looking at the results, the caregiver ECD knowledge scores, you can see the graphs. The red represents the control, the green is the health facility plus home, and the blue is the health facility-based package. So you can see that at midline, which is the post-birth 2, when the children were aged 9 to 10 months, the differences between the control and the intervention arms were not significant. That's for caregiver knowledge. Caregiver practices at midline, next slide, please. At midline, the caregiver practices, we saw that the intervention arms were significantly different from the control arm. Midline, when the children were aged 9 to 10 months. At endline, when the children were 24 to 27 months, the 3 arms were converging around the same scores. So the differences were no longer significant. Looking at children's developmental outcomes, we saw also at midline, the intervention arms were significantly different from the control arm. However, at endline, there were no significant differences across the 3 arms. Some of the considerations that we make on our results, we realized that at post-birth 4, towards the end of 2020, nurturing care had been institutionalized within the entire county, which meant that caregivers in the control arm were also exposed to the nurturing care messages. Some of the barriers that were noted, like staff transfers, inadequate staff, high workloads, low staff motivation, and competing demands on CHVs may have affected implementation of the intervention. And then we know, or we saw, as you can see in the photo on the right, COVID-19 affected implementation. Whereas before COVID, the CHVs were able to get into the caregivers' homes and speak to them. Because of the restrictions from COVID, they needed to carry out the home visits when they were outside. And you can imagine that environment, being outside, discussing, maybe some of the issues that were discussed were a bit private. Maybe it was not very comfortable for both the CHV and the caregiver to have this visit carried out outside the house. We say, just to reflect on our results, integration of ECD counseling is feasible at the facility and community levels. And then we did not see an additional impact from the health facility plus home-based arm. We expected that because of the additional ECD counseling that caregivers received at home, we expected that the caregivers who were in the health facility and home-based arm would do better than the ones in the other arms, but they did not. And then the significant effects that we saw at midline seemed to have washed out at endline. So in conclusion, next slide, please. Next slide, thank you. There is value in integrating ECD counseling into health facility visits. However, the unstable trends that we saw show that more needs to be done so that we can have sustained impacts. And then integrating ECD messages into health systems is feasible with regards to performance, usefulness, uptake, and efficiency in service provision. Some of the recommendations that we make based on our findings, there is need to consider staff workloads when implementing interventions, and especially when you think about CHVs and the competing demands that they have from different projects that may be running at the same time. The caregivers in Kenya, we've seen these reports from several studies. Caregivers tend to fall off from visiting the health facilities regularly after the 9-month visit. And this is when their children receive the last important, what they consider important in quotes, last important immunization, So there's need to encourage them to keep coming to the health facility even after that 9-month visit. And then interventions need to consider integrating in ECD counseling beyond the initial immunization visits. And there is need to vary the intervention components according to participants' characteristics and needs. For example, literacy levels, marital status, and age. Marital status has to do with the single families, or rather single caregivers, single female caregivers may receive an intervention differently from those who are married, because the single ones may be facing more stress at the household level and may therefore not be very receptive because they are thinking about all the other issues that they need to sort out within the household. And then there is need to consider male-specific intervention activities. We know from different study findings and also from anecdotal reports that males tend to be a bit reticent to be part of activities that they consider to be female-oriented. So if we have male-specific intervention activities, we're likely to see more engagement by the male caregivers. Thank you very much. That's the end of my presentation. I'd like to acknowledge the APHRC research team, the implementing partners, the MOH partners, our MOH stakeholders, and then the strategic advisory team that supported us throughout the implementation and the evaluation of this study. Thank you very much.
Thank you. Thank you very much, Patricia, for sharing these results and for giving us a rounded presentation that had showed us some similar aspects with what we heard from the previous presenter, but brought in this additional dimension on tracking children's development at different points across the life course, where then in your recommendation, you made some suggestions to say, actually in terms of exposure to the intervention, does the intensity stay the same, or is there also work needed to ensure that stability of being consistently supported as caregivers through services as well as in the community? So lots of food for thought here that hopefully we will have some time to unpack. Now, in order to move us forward in the agenda, I like to ask our next two panelists to open their cameras, and like to identify Dr. Caroline Mwangi and Ms. Arla Alfandega to join us. So, Ms. Caroline Mwangi, I'd like to start with you. You are the head of Division of Neonatal and Child Health in the Ministry of Health in Kenya. You are an ECD champion, and you've played an important role in the development of newborn child and early childhood development strategies and guidelines in your country. At the same time, you are a mentor and you train health workers, so you have a clear connection with what is happening on the ground and a keen interest in health systems. So based on the findings that we have heard in the two previous presentations, would you share with us, first of all, a little bit about the vision? What did the government of Kenya intend to do in engaging with the pilot initiative in Siaya County? And now that you are looking at the results of the evaluation, what are the lessons you are learning from here, and what are the implications for what you will do next? May I give you the floor for 5 minutes or so?
Thank you. Good morning, good afternoon, and good evening to all. Thank you for the two presentations, Joshua and Patricia. So for us at the Ministry of Health in Kenya, we have the Nurturing Care for Early Childhood Development Program. And this program focuses on how we can implement the Nurturing Care Framework Strategy of 2018. So we have various strategies, as we've seen from the study, that we need to integrate all the components of the Nurturing Care Framework and try and integrate it into routine healthcare systems. So in Kenya, we have achieved several milestones, and some we're hoping to achieve in the course of the year. So the first step towards integration, as we said, we first focus on the policy environment. How can we strengthen the policy environment? So currently we're in the process of updating the early childhood development policy. So it's being finalized, and this policy gives a framework for how these strategies can be integrated, the multi-sectoral approach that is required, and coordination led by the related sectors of government, with the Ministry of Health taking the lead. And it will also give us a roadmap as to how we want to implement the nurturing care framework, and we hope to also develop an implementation strategy. Then when it comes to, we also have an advocacy strategy that is also being developed, that looks at each of the components and how we can advocate for one, allocation of resources, because you know, without adequate allocation of resources, our implementation can only go so far. So advocating for implementation of the nurturing care framework at both at the county level, advocating for resource allocation of both national and county level, and how we can support the various components and work together as multi-sectors involved in early childhood development. Then when it comes to the health workforce, we have the Care for Child Development training guidelines for healthcare workers. We also recently developed the Care for Child Development training guidelines for our community health volunteers to be able to deliver these interventions at household level. So plans are in place to finalize, launch, disseminate, and scale up these trainings. At the facility level, we have our Mother-Child Health Handbook that has guidance on care for child development, how to communicate and play with your child. So this booklet is supposed to be used by the healthcare worker when they're counseling the mother all the way from antenatal to when the child is 2 years or older. Patricia indeed pointed out the challenge we have of caregivers dropping out of coming for well child visits after their child has received their vaccine. We have the second measles dose at 18 months. However, we believe that with increased sensitization by the healthcare workers on the importance of continued visits, we'll see an increased uptake. So at the healthcare facility level, we also have monitoring of the developmental milestones, and this has been incorporated into our monitoring system, the Kenya Health Information System, where we are able to track how many children have been assessed for developmental delay. So we hope to review and refine this indicator in our next round of indicator reviews. So we also, the strategic plan for the division of neonatal and child health, a key component of that strategy is Thrive, early childhood development. So we give counties a framework for implementation and what strategies they can implement or use to ensure that they're integrating these components into monitoring of children. Then, so we want to scale up trainings. And then we are also planning for a survey, which will, the Kenya Demographic and Health Survey, which is slated to start this month. It has a whole component on early childhood development. And we are looking forward to having these results and seeing as a country our position as far as development is concerned in children aged 2 to 5 years. So in brief, that's unless there are more questions, that's you can say that's how we are using what the study showed as integration being important. Thank you.
Thank you. Thank you very much for touching upon multiple aspects. Is it reminding us of the multi-sectoriality, the fact that there needs to be policy as well as investment, and then to look at the role of the health services and what it can do there. In terms of data, you highlighted the importance of data, and so using the forthcoming survey to generate more data that can serve for that political advocacy to keep the effort strong is very central. We will be on the panel, so more questions may come, so stay tuned for that. But I like now to invite your counterpart in Mozambique, Ms. Arla Alfandega. Are you there, Ms. Arla? There you are. You are the head of the Child Health Section and ECD focal point at the Department of Maternal and Child Health at the Ministry of Health in Mozambique. You have taught and supervised health providers as part of their pre-service training, and you have served as a head nurse in a pediatric ward. So you have experienced and seen some of the challenges that have come through the studies firsthand. So would you like also to share your reflections around the implications of these findings for the government of Mozambique to take that important work that was started in Manapu province, to take that forward into the overall programming approach? Because as Svetlana indicated, you already had monitoring of child development in sort of your counseling and service package. What have the study provided you in terms of inputs for saying, what are we going to do next? Over to you.
Boa tarde a todos. Muito obrigada pelo convite e por partilhar experiências de Moçambique. Também agradecer ao Joshua e a toda a equipe que fez o estudo cá em Moçambique, principalmente em Monapo, numa área rural. Foi de grande valia de testar exatamente como o DPI pode ser integrado a nível comunitário com poucos recursos, poucas capacidades técnicas, então foi um desafio. Em relação à questão sobre a integração do DPI, queria aqui partilhar que o Ministério da Saúde, desde 2018, quando houve o movimento global, teve preocupação de sempre pôr esta estratégia de DPI a nível dos programas, principalmente nos programas de saúde materno-infantil. Caiu numa altura que estávamos a fazer pela primeira vez a revisão dos instrumentos de saúde infantil a nível primário, onde integrou-se numa primeira fase apenas um indicador, porque na altura tínhamos pouca informação em relação ao DPI, e o que nos preocupava normalmente era fazer o rastreio dos atrasos de desenvolvimento através daquilo que é a monitoria do crescimento e desenvolvimento a nível dos provedores, numa altura no impacto nacional. Entretanto, houve várias iniciativas locais, que muitas das vezes lideradas por parceiros, principalmente a PAT, a OMS e a Unicef, em relação ao DPI. Temos como mais-valia, porque queríamos integrar o DPI para fazer parte de uma forma sustentável, não como um projeto novo, mas que pode acompanhar os projetos já existentes, integrar-se a nível dos nossos pacotes de formação, a nível da formação pré-service. Isto está a ocorrer paulatinamente a nível do Ministério da Saúde. Entretanto, precisamos ainda de ter mais investimentos e mais apropriação para constar naquilo que é as políticas próprias do setor. Por isso que, com a ajuda dos parceiros aqui, nós criamos um grupo técnico a nível do Ministério, que focaliza exatamente o DPI, para que possa englobar a maior parte dos programas e assim termos mais sustentabilidade nas nossas ações. E atualmente estamos a finalizar um plano de ação virado especificamente ao DPI, em que engloba exatamente esses setores, e também um pacote de formação mais padronizado para que também os parceiros que queiram apoiar e que possamos desenvolver este pacote de DPI. Concretamente, ao estudo aqui apresentado, nós agradecemos, porque é mais uma informação e mais um conhecimento que nós podemos agregar, feito com evidências aqui em relação à realidade. Entretanto, há desafios que o próprio estudo mencionou e também muitas lacunas e limitações, muito acerca da pandemia que ocorreu na altura, que se podia fazer melhor acompanhamento ou colher maior dado que pudesse subsidiar ainda mais os resultados ali apresentados. Normalmente temos sim problemas de recursos humanos. Nós sabemos que as nossas unidades sanitárias, a nossa cobertura sanitária ainda não cobre toda a população. Entretanto, mesmo com essas condições, foi possível fazer-se o trabalho, ter o feedback em relação ao pessoal, em relação à implementação deste projeto a nível das unidades sanitárias. Portanto, o que nós gostamos e foi de grande valia que vai nos subsidiar as nossas discussões aqui a nível do grupo técnico, a nível do setor de saúde, é que é possível fazer a intervenção, a aceitabilidade, né, dos utentes, assim como dos provedores, com alguns aspectos que podemos levar em conta por forma a minimizar e termos maior credibilidade. Entretanto, ainda é um desafio, queremos mais sistemas de monitoria, mais intervenções em relação aos indicadores para que possamos medir exatamente as nossas intervenções e conseguirmos ter ainda mais subsídios para fazer advocacia, que era a nível das lideranças. Como bem disse o estudo, mostrou-se uma liderança muito forte a nível da direção distrital, a nível da direção do hospital. É mais fácil que a aceitabilidade e o decurso normal das atividades cursam da melhor maneira. Portanto, é mais investir nesta área, não fortalecer. E queria desafiar também ao nosso investigador que não deixe de fazer outros estudos em Moçambique, talvez um pouco mais aprofundados, comparativos nas outras áreas que não tenham assim muita intervenção como foi feita neste estudo e conseguirmos ter mais conhecimento, mais evidência de como desenvolver o DPI e fazermos a expansão paulatina a nível do país. Obrigada, não sei se tem mais algum acréscimo, era só isso que queria partilhar.
Thank you, Dr. Ala. That was excellent. And I think there are so many things to reflect upon, but at least you brought forward the point of commitment, the readiness that you have in the country to take this to scale, but then also the efforts that are needed to kind of create that commitment at all levels, plus the resources in order to translate that commitment in actions in order to get a strong program. So I would like you also to stay on as a part of the panel, because we are getting now into the last part of our session, where we are going to look at some question and answers. May I ask all panelists, presenters, to open on their cameras so the panel is visible to all. Wonderful. So let me start with a first question that came from Maurice Mutsia. And that question is about the care providers. How can we motivate frontline workers to change their practices and sort of their perceptions about the interventions? How would that influence their capacity to take them up? I suggest that panelists put up their hand if they would like to answer this question. Who would like to go on this one? Yes, Svetlana. Mm-hmm.
So I think because we work with the government system, we cannot introduce financial motivations or motivations that really would probably undermine, right, what we're trying to achieve. So we have to look at other motivating factors. Sometimes it's a bit of competition between maybe health facilities, between providers, right? Looking at each other's data, monthly comparing the results, the achievements. So I think that's what we've been doing so far. But we are definitely hoping to do more, and I think that's why we are planning to engage in human-centered design this year to really identify what motivates providers as individuals and as a cohort, both at community and facility level, so we can dive deeper in the motivating factors as well as barriers and address them as we are refining the model. Thank you.
Thank you, Svetlana. You used that term, the human-centered design, is it? So that's a specific methodology in order to unpack some of the perceptions that even the providers may have that either facilitate or enable the uptake of the interventions alongside the resources they are provided with through the system that they work in. That's excellent. I think we are all looking out to kind of learn more about that. I see Joshua would like to contribute as well. Joshua?
Just very quickly, yeah, I'm remembering the data and how providers talked about warm and positive supportive relationships with their supervisors. And I know that that's something that has been more intensively infused into the Mozambique program. And so I think continuing that stream, I think, can potentially be, just in terms of a relationship perspective, knowing that someone cares for them, is giving them feedback, wants them to succeed. I think that may have potential as well.
Yeah. Dr. Caroline and Ms. Arla, you being so close to the field and having that deep concern for the workers, would you want to share some reflection on this? What is it that when you are at the front line can be done in terms of supporting workers to enable them to uptake what I think the results show they have a keen interest in? Now it comes how to translate that into practice. Who would like to go first?
I can start. Thank you.
Yes, please.
So I think like one of the strategies I wanted to mention is that in addition to continuously having, in Kenya we call them continuous medical education sessions, CMEs, to healthcare workers on the importance, once we emphasize the importance of these interventions and the effect that it has on the early childhood development and especially brain development. Another strategy we're using is to try and incorporate the nurturing care framework components into the pre-service training. We start sensitizing healthcare workers right from when they're being trained, so that as they exit training and join service, they're already sensitized and they're already aware of some of these interventions and what role they can play when they're attending to children at all levels of care, be it the sick child or the child who's come for continuous growth and monitoring. And together with, we have a collaboration with the Kenya Pediatric Association, the Ministry of Health, and the American Academy of Pediatrics. We developed a curriculum for pediatricians, training curriculum on early childhood development. We can use this as a learning opportunity to also scale up to other cadres of healthcare workers, so that we're continuously educating, continuously sensitizing and training them, so that they take an interest and have have the will and support these interventions that we want to roll out as a country and as counties. Thank you.
Thank you. And with practice comes routine, is it? And with routine comes time savings. And so the system incrementally will boost itself as sort of these inputs are given. And Ms. Ala, would you like to add to what your colleague has said? You may be speaking, but
alguns
yes, yeah, we
aspectos,
have.
sim, são esses que a colega do Quênia explicou, mas também nós estamos a tentar incorporar mais parceiros, principalmente aqueles ligados ao HIV, que tem maior número de formações, fundos a nível dos parceiros, para que eles também se interessem por esta área do DPI, porque lá também tem as crianças vulneráveis que precisam dessa estimulação, as crianças desnutridas, as crianças vivendo com HIV/SIDA, então podíamos também abarcar essa área muito importante para que elas também tenham este contacto, esta intervenção em relação ao DPI. Então é uma das estratégias que estamos a tentar usar, mesmo a nível hospitalar, no tratamento das crianças com desnutrição a nível do internamento, para que elas possam recuperar-se mais facilmente quando estão naquela última fase de tratamento. Então, são algumas intervenções e formações em trabalho. formações de curta duração, temos pacotes elaborados por parceiros da parte que versam exatamente sobre aconselhamento ou a estimulação de um curto período, só para ter maior número de provedores que possam estar alinhados ou em contato com a teoria de desenvolvimento, porque a nível dos currículos leva muito tempo para que esses ficam acomodados e as formações não param, os colegas estão a sair, então sempre vamos ficar neste ciclo de ter um profissional formado enquanto estamos à espera do currículo. Entretanto, vamos fazer essas formações pontuais a nível da unidade sanitária, principalmente aos recém-graduados que apresentam-se às nossas unidades sanitárias.
Thank you very much, and thank you for bringing out particularly the children who may be at highest risk, children with HIV, children who are stunted. Those we want to reach all families and children, but then there are those that need the extra help, as Svetlana showed in the pyramid. So in that respect, there was one question from the audience around children with disability. Are they incorporated in the services that are being provided in the two areas where the studies were done? And what is kind of known about the impact that the interventions have on them and their families? Who would like to take up that question? Go ahead, Dr. Ala. Please.
Aliado à pergunta, em relação à deficiência, nós estamos a preparar um pacote adaptado do ECD a nível da Universidade de Liverpool, que está sendo usado no Malawi, para que possamos, além do rastreio do atraso de desenvolvimento, também possamos incorporar a deficiência. Também incorporamos alguns dos indicadores de deficiência num estudo demográfico que pretendia se realizar ano passado, talvez este ano possamos realizar por conta da pandemia, e incorporamos alguns indicadores que possam depois nos dar algum subsídio sobre a magnitude em relação a esta situação a nível do país, para traçarmos as políticas concretas em relação a este grupo de crianças.
Thank you very much for those reflections. It's clear that we are looking here at an agenda that is broad, has multiple ramifications, has a central role for the health sector, but requires all other sectors around it. And so as we look at this outcome, early childhood development as an outcome, what are the inputs we need to generate? And so within the two implementation sites, important efforts were made to strengthen health and nutrition and put these additional interventions around early learning, responsive caregiving, monitoring early childhood development, and facilitating referral for extra support when needed. I see we are at time of this webinar, but I'm asking the indulgence of the participants to stay a few minutes longer, and I would like to invite our one colleague and convener of this webinar, Matthew Frey, to share with us a few thoughts that after many years of having invested in this area, assisting and working with different country teams to move it forward, if you were to summarize a few essential steps that are necessary for getting started, for those people in the audience who may be at the early stage, as well as what you see as essential requisites for sustainability of the effort, would you be able to give us a few sort of takeaway messages that we can hold on to? Matthew?
Bernadette, thank you. And thank you to all our panelists for an excellent webinar. I think we have covered an enormous amount of ground, and we've really had a lot of insight into the processes that we follow as we journey over the last 7 or 8 years towards stronger integration of child development. And we are seeing, I think, just to highlight a few key features which have been critical to the successes that we've heard about in Mozambique and Kenya today. And first of all, I think it starts with leadership. Leadership within the Ministry of Health, and I want to thank and commend our ECD focal points on the panel today. The setting the policy agenda, creating the technical guidance, the broad enabling environment that facilitates the uptake at service delivery level and set standards and guidances is critical, and it begins with you. I think we've also heard about the importance of multi-sectoral coordination, and we've seen some great examples of how government leadership beyond the health sector also plays a critical and supportive role. So I know we are over time now. Let me stop there. But I do want to just thank our colleagues, and Bernadette, thank you for the excellent moderation and the leadership that you have provided over this last decade and more to make a lot of this work possible at the global level. We have a wealth of tools and packages and materials we can now draw on. And I think the challenge before us is to promote some of the learnings through forums like this, so that we can cross-fertilize and begin to take these important lessons to other countries that are setting out on this journey. Thank you.
Thank you, Matthew. Thank you for these remarks, these messages, and illustrating as a community, we are on a learning path. Is it? We know where we want to reach, but now we need the experience that may be different in different systems of how to get there. So as Matthew's alluded to, we have a rich community of different constituencies that are investing in it. We have platforms through the ECD Action Network, the Nurturing Care website, the website that promotes the work that PATH is doing to share information, to share the lessons. The initiative, the fact that was invested in these studies to really find out what is happening here in terms of this acceptability, feasibility, and even some impact are critical. And so as we look at what we have learned in the past 4 years since the Nurturing Care Framework was launched, then one of the key messages is start small, document well, learn your lessons, and move to scale, so that progressively one can build the resources, implement, learn on how that can be done effectively, collect your data that can be used both for strengthening the program and for advocacy at a political level, and move forward. We are at an agenda that cannot be achieved overnight. And so the aspiration to say we do small investments and tomorrow we see the end result of it, I think all of us need to come to terms that that is unlikely to happen. But as we progressively can show the improvements, the willingness, the readiness in the system to engage and to deliver the messages, and we can strengthen our monitoring around that on what's happening on that care pathway and what happens in home in terms of home care, and we find positive results across health, nutrition, early learning, responsive caregiving, and safety, then I think we can be confident to say progress is being made towards reaching this ultimate outcome of seeing that children's development is improved, human capital unlocked. So with these remarks, I have to bring this conversation to a close. Many of us might want to continue. We will find other ways to do that in different fora, and I'm sure some of the panelists here will be very happy if you reach out and ask for some more information around what you have learned or heard. The ECDAN platform will also help us to make this webinar publicly available. Thank you very much, presenters, panelists, for all the preparations, the good work. Thank you, conveners, for giving us this opportunity to be together. Thank you, participants, for being very active around these attentive listeners and providing your reactions to the Q&A and chat. So goodbye until we meet again.